Sometimes you have a contained rupture, sometimes it's just a hematoma, sometimes you have a frank dissection with a big defenestration. When we look at the North American experience quite a few years ago, found that this is actually from aortic centers with experienced FOD surgeons. So the dissection can be up to, the mortality can be up to 17%, and if you see FOD in the periphery, can go up to 26 or 38%. This is a brand new paper that was published in 2025, where we look at patients with malperfusion, we look at the STS database, and you can see that people presented with malperfusion, and only 1/3 of them, they don't really do well, and even the ones that they don't present with malperfusion, the mortality can be up to 13.6%. So it's quite a morbid disease with significant mortality. This is a patient that I just did a few days ago. So when we see a patient like that, the first thing is the patient needs to be alive. That's extremely important. The second one is if there is malperfusion, to resolve the malperfusion. And then we think about the downstream aorta down the line if the patient actually is alive. This is the guidelines, the ACCHA, which I had the privilege to be a co-chair on, where actually there is a really very, very detailed way of how we treat a patient with malperfusion. And one thing to make sure is that, and we understand, is not all the malperfusions are the same. So this is one of the most common repairs that the cardiac aortic surgeons do, and this is proximal arch repair with valve suspension. And this is a really good operation. The important point here is that this, when you do the repair, this is an open distal anastomosis, meaning under circulatory arrest. Now, we have found over the years that if we have a stent to the descending thoracic aorta, this potentially can be beneficial, especially for patients with malperfusion, and malperfusion of the kidneys as well as malperfusion of the lower extremities, but not in the mesenteric. And multiple actual papers show that, and how the stent is delivered. The stent can be delivered antegrade during the circ arrest, or retrograde from the femoral. And on our own series, we do usually antegrade during circulatory arrest. We did find that these patients, they have better survival, and we get 5 years when we look at the long-term, the mid-term outcomes, as well as the remodeling of the descending thoracic aorta, not the entire thoracoabdominal aorta. This is also important. The descending thoracic, where the stent was remodeling with thrombosis, and potentially, even though the numbers are small, the reoperations were actually less. One thing to mention here is that these two things are not the same. The second picture is actually total arch with a frozen elephant trunk, where we have to reimplant also the head vessels. How we do it, place the stent with the antegrade during the circ arrest. We have found initially that we had a lot of fender leaks on the outer part of the aorta, and then we start actually placing circumferential stitches around the stent and with the graft. And this is how it looks like. Now, one of the pitfalls is that this stent actually can go in and out of the true and false lumen, and this is a case where we have actually to cross and put the stent from the true lumen to the false. Now, if there is malperfusion and the lactic acid is high, in this case, because these patients, they have a very good outcome, and there is delay, you have to do the central aortic repair first versus the malperfusion. We have actually found that one of the things that can be done is place a stent on the descending, and if the patient survives and depends how he does, potentially you can actually come back and treat the ascending aorta. That was one of our patients. And again, so if there is visceral malperfusion, doing the TIVAL first makes sense. If there is distal malperfusion on the legs or the renal, then doing the central repair and potentially placing a stent is another treatment strategy. Thank you so much.